All right, in this recording, I'm going to kind of go over bundle branch blocks. So we got our L, B, 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 and our R, B, B, B. Right bundle branch and left bundle branch blocks, okay? And I'm going to draw two hearts. Heart number one. Heart number two. They're beautiful. Wouldn't you agree? Looks just like a heart, I think. I think it looks like a heart. Yeah, no, it doesn't look anything like a freaking heart. All right, so there we go. We're drawing our hearts. And let's draw our, there's our SA node, AB node, no problems there. Bundle, or the bundle of his. Now I'm going to draw the right bundle and the left. Now I'm going to draw them a little weird, and you're going to go, wait a minute. And that's because, remember that the left bundle branch has two fascicles, and the right bundle branch only has the one. It's just the right bundle branch. But I'm drawing those little red guys just to kind of highlight the actual bundle itself, the bundle branch itself, not the fascicle. Highlighting the bundle branch. And I'll do it over here too. Ah! I went too far. Got too crazy. Got too excited. Yeah, can't do that. That's bad. Bad stuff. All right. La-di-da-di-da. All right, there we go. That's good. And then we'll draw coming off of here. Here's our little left. There's our left. And okay, all right. So there's the left goes off that way. There we go. And then the right goes off that way. Okay, so now what we're looking at is really poorly drawn hearts, to be honest. But what we're looking at here is we're going to talk about why we see what we see on the EKG. Now, you know that positive deflection on the EKG, upward deflection, that means that what I have is that electrical signal traveling towards the positive lead, okay? And the leads that are the most important in recognizing bundle branch block, we have V1, lead 1, and then lead V6. Well, this is first, and then these are the second ones that I go to. The first one I go to is going to be lead V1, and then lead 1 and V6. Obviously, you're going to start off like you always do, just reading your EKG, looking at your EKG, and then noting something's wrong. And what you normally see is that you see a P wave with some sort of wide complex. Well, the very first thought when I see a P wave with a wide complex is I might have a bundle branch block. Let's figure out what the heck's going on. All right, so let's deal first with our left bundle branch block. So let's block this left bundle branch, okay? And so that means that the electricity is going to go down and out the right bundle branch, and then it is going to be depolarize the left ventricle, but in order to do so, it has to go from cell to cell to cell to cell to cell and depolarize that, okay? It's not traveling I-90 or I-39 or whatever. It's traveling all the back roads, right? So instead of going to Chicago via I-90, it's going to Chicago via, you know, all those weird back roads going past Lake Geneva and then down and then over to Gurney and then Crystal Lake, Illinois, and all that kind of stuff. So that's the thing. It's taking those back roads, and it's going to take more time. It's going to take maybe a little bit more energy, but definitely more time, okay? It's going to take a lot more time. And so we know that on our EKG, when we're looking at our EKG, the lines sort of going this way and this way, we measure, you know, obviously from this line to this line, this line to this line, right? That's vertical. That's the horizontal lines. So between those lines, we're measuring energy, right? We're measuring millivolt. But from point to point on the EKG, let me erase this real quick. From point to point, I would be measuring time. So that means that as this widens out, okay, on the EKG, if the QRS widens out like that, then there's an increase in time from that EKG rather than this EKG, right? Okay, so that means that it takes more time to depolarize. And that's why we look at lead 1 and lead V6, right, is because in the end there, in lead 1 and V6, those lateral leads, what I should see in a left bundle branch block is a slow upward deflection in leads 1 and V6. Slow upward deflection because we're going from cell to cell to cell to cell to cell to cell to cell. Well, in a right bundle branch block, it'll sort of be the opposite. So let's take this guy and let's block the right bundle. Okay, there you go, blocked the right bundle. And now what we see is that electricity is now coming down all the left side. It's coming down the left bundle branches, and then it's going from cell to 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 cell, back that way, okay? Which means that in our lead 1 and V6, which lead 1 and lead V6 would be over here, we should see downward deflection, and we should see wider, sort of lazy downward deflection. Well, let's take a look at this on an EKG. All right, so here's a left bundle branch block, right? We're looking at a left bundle branch block right here, and we know that the very first thing we do when we're looking at EKGs, we look for P waves and QRSs and all that kind of stuff, and we kind of identify those things. So the first thing that I note is that there are, in fact, P waves. There they are. They're not that easy to see, and I can't draw good arrows again today. I don't know what's going on with me, but so there you go. The P waves are there. You can even see there's a P wave there, P wave there, right? So the P waves are there, and that means that something weird is going on because I have a P wave and a wide complex. And I told you in class, the best thing to do when you have a P wave and a wide complex is to just say to yourself, it's probably a bundle branch block. I have to figure out if it really is. And the very first thing that I want to do is I want to go over here to lead V1. Right? And on lead V1, what I'm looking for is I'm looking for, in a left bundle branch block, I am looking for mostly downward deflection because that tells me that the vast majority of that energy is going away from lead V1. And this is true because lead V1 sort of sits over the left side of the septal wall, and well, more like the middle of the septal wall, and that sort of shows this rightward shift, okay? Sort of a rightward shift to the heart. And that's exactly what's happening, right? Because all of the electricity is having to go through that right bundle. It can't go through the left bundle. It has to go through the right bundle in order to make its way then down that right bundle, sort of taking the back roads. So it goes down the right, oh, darn it. It goes down the right bundle. It sort of takes the back roads. It's not going I-90 or anything like that. And then, yeah, it finally gets to where it needs to be, and then it can repolarize, okay? So it's all in V1 sort of going away from lead V1, all right? Now, if I look at leads 1 and V6, what I should see, because all of that energy is going to go from one side of the heart, the right side of the heart over here, to the left side of the heart. So all of that energy is going to be going back that way, and in leads 1 and V6, so if that's lead 1, this can be V6. In leads 1 and V6, what I should see is almost all upward deflection. And if you look at it, there it is. Okay? Look over here at lead 1. You could even look in some other lateral leads. Now in V5, it's a little tough because V5 actually is sort of on the edge between a lateral and between the lateral wall and the anterior wall. So you're sort of getting like an isoelectric here. So that doesn't tell me much. But boy, look at AVL. AVL is almost all upward, big R waves, right? Big R waves in lead 1, lead V6, big R waves in lead AVL. That means at the end, everything is going towards those lateral leads because it went down the right side and had to come backwards using all of the back roads to depolarize the left. Well, let's look at a right bundle branch block, okay? Very first thing I do, I look and I see, oh, look at, yep, there's P waves. There they are. Okay, no problems there. I'm seeing P waves. There's plenty of them. You can find them anywhere on here. Those are all P waves. Good, that's great. Great to see, okay? Well, I got P waves, and then I've got this weird sort of wide complex. I don't know. Some people say you should see the RSR prime pattern. You do see RSR prime, okay? RSR prime is there in those leads, and that's fine. You know, again, if you're looking for bunny ears, you're not fucking bunnies. Anyway, you know, don't just look for bunny ears. All right. Don't just look for RSR prime, although many times you will see it in a right bundle branch block. You will see RSR prime pattern, but don't just look for RSR prime pattern. Look at all of the other stuff. And so in this, what I see is there's my my J point, right? And as I work backwards from my J point, what do I have? I have upward deflection in V1. Look at that. There it is. It's upward deflection. So up is right, down is left, just like the turn signals. We all know that, right? And so then what I want to do to confirm in my V6 and my lead 1 is there sort of a lazy S wave? And if you notice, yeah, there is. There's kind of a lazy S wave. And if you look at more right bundle branch blocks, and we will in class, you can see there's sort of this lazy S wave. It's not really good, you know, it's not a really good S wave. Most S waves, when you see a QRS, you know, you expect the S wave to come right back up. You know, there's almost no time between the end of the R wave and the S wave. And obviously here you can see that there is, okay? And you can, again, look at all your lateral leads if you want to. You will see there's sort of this lazy S-wave pattern. You can even see it in this one in V5. You'll see this sort of lazy S-wave pattern. And there you go. There's your S-wave going back up. And that's because at the end there, at the end of all of that electrical activity, now everything has to travel on the back roads from left to right. Okay? So there's the right side of the heart. There's the left side of the heart. Now everything's traveling in this direction, from left to right, okay? Because it all went down the left bundle branch, no problem there, and then had to go back roads, you know, cell to 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 cell in order to depolarize that right side. And so that's why in my lateral leads, which sit over here, okay, lead 1, V6, again, in this one you can look at V5, and in this one you can also look at AVL. That works as well. Okay, but in those lateral leads, what I'm seeing at the end there is I'm seeing the electrical activity traveling away from me. Okay, in V1, I'm seeing the electrical activity sort of at first it travels towards me, then it travels away, and then it travels towards me again, and then it is away again. So you can kind of see how it's like, you know, the electrical activity kind of, okay? Same thing, you know, obviously there you go, there's your RSR prime. And that's why RSR prime is a very popular thing to look for, because in a lot of bundle branch blocks, yeah, you will see it. You will see it. It's there. But it's not there in every right bundle branch block. So don't be, you know, don't be just hunting for bunny ears and carrots sticking in the ground and stuff like that. Okay? Plus, you know, it kind of makes you sound dumb. I don't know. Every time I hear somebody say bunny ears, like, bunny ears, really? Like, you couldn't just figure out on the EKG there's an RSR prime pattern possibly, and then there's an S wave and stuff. But anyway, hey, right, it's fine. It's fine. Bill's being William again. I'm trying not to. All right, so that's what I've got. So when I look at my right bundle branch block, mostly upward deflection in V1, especially when I go from the J point backwards. And then in my lead 1 and V6, I should see S waves. I should see pretty good looking S waves there. And then once I've got that, I know this is in fact a right bundle branch block. All right, so let's talk very, very quickly about Sgarbossa's criteria. And I'm going to go back to left bundle branch block because Sgarbossa's criteria is something we use for left bundle branch block, not really for right bundle branch block. We use it for left bundle branch block. And the problem with left bundle branch block is that it has a tendency to hide ST elevation on us, okay? I mean, if you look at this, look at your precordial leads, look at your mid-precordial leads, right? Look at these guys right here, and you can even add V4 into that if you want to. You look at these guys, and what you see is the J point that could be anywhere like up here, you know, could be a J point up here. I mean, we could say this is the J point down here. That's fine, right? But if you're looking at it, you think, geez, that T wave goes way up. And, maybe it's a De Winters. No, it's not a De Winters. Relax. It's just a left bundle branch block. All right? And so what you're seeing here is you're seeing this massive sort of, T wave now coming after that QRS, right? And remember when I said you have weird depolarization in a QRS, you're going to have weird repolarization in your T wave. Okay, so that's normal. That's normal to see. So here's the thing about this is that most of the time what we've said is you cannot tell with a left bundle branch block whether or not that patient also has a STEMI. Well, that's complete bullshit. That's bullshit. I've told you it's bullshit. It's bullshit. Okay? Because we can tell. And what we use is Sgarbossa's criteria. And what Sgarbossa's criteria says, there's Sgarbossa A, there's Sgarbossa B, and there's Sgarbossa C. Okay? And Sgarbossa A, what we see with our left bundle branch block, okay, and again, this can be pretty much in any lead. You could look at any lead and say this, is that, and I'm going to sort of draw it as if it were in V1, okay? So there's your big, okay? And then what we see is we see that we go up like so, okay? If we have the QRS traveling in this direction and the T wave ST segment traveling in this direction, Dr. Sgarbossa told us that is what we expect. That is normal. We call that, I'm going to pause because I'm hoping some of you are saying it at home, discordance, right? Discordance. We call that discordance, and we expect to see that. That's actually a good thing, okay? What we don't like to see is concordance. Now, I'm going to try to draw this. I'm not going to be good at it, but I'm going to try to draw it, okay? What we don't like to see is we don't like to see concordance. So now let's talk about, we got it like this, and then we notice that we've got this sort of, that's not going to work. Hold on, let me clear that one out. Let me draw it the way I know to draw it. That'll work better. All right, so we kind of go here, right? And then we see this, and then we see maybe a QRS that's sort of going up in this direction, right? And then we see this, okay? So we have still a weird bundle branch, okay? And again, this is no longer lead V1. This is maybe, this could be lead, let's make it lead 1. What the hell? Okay, it could be lead V6. Could be lead, it could be lead V5. It might not be, but it could be lead V5. Could be AVL. Who knows, right? But what we're seeing here is we're seeing concordance. We're seeing an upward QRS, and then we're seeing that we have elevation above that baseline. Now, you guys are good medics. You're going to find that damn near every time. You shouldn't have a big problem with that. But you'll get some medic that'll come along and say, well, he's got a bundle branch block, so I can't tell if it's actually a STEMI or not. Oh, yes, you can, okay? This, if you don't call this a STEMI, you have a big problem. You're going to bring this patient to a hospital that doesn't have a cath lab, and the ER doc is going to lose his mind, okay? And he has every right to. He has every right to, okay? So if in all of my leads I see something like this where I have discordance, then I'm happy. I'm happy. I don't fit Sgarbossa criteria A. I only fit Sgarbossa criteria A if, there you go, right there, okay, if I have this abnormal, if I have this concordance and we're talking about ST elevation, okay? Sgarbossa B is a little different. Sgarbossa B, in order to be positive for Sgarbossa B, would look something like this, okay? And so what I'm now seeing is, I'm seeing discordance, right? Boom. Downward ST segment, upward T wave. That is, oh, excuse me, wait a minute. You know what? I drew the wrong thing. Hold on, let me go back for a second there. No, I did all right. That was fine. So what I just didn't label was this guy right here. I just kind of forgot. Okay, so I got my QRS going downward. I've got my ST segment going downward. My T wave is going up, and we think, well, that's good. That's good. That's discordance, right? No, that's not discordance. No, no, no. Okay, because we have concordance of the ST segment and the QRS. which actually this is the one what I drew was not a QRS, but that's okay. So I've got this downward deflection of the QRS, and I've got this depressed ST segment, right? So here's my ST segment depression. I have a downward QRS, and that is concordance. Concordance is bad. We don't want to see concordance, okay? And this is Sgarbossa criteria B. If I have downward deflection with my ST segment, I have downward deflection on my QRS, and you look at this usually in V2, V3, and V4. That's where I'm looking for this. And it can be in any one of those leads. It doesn't have to be contiguous. It just has to be in one of those leads, V2, V3, or V4. If I see this in any other lead, okay, this works, this one up here, this up here works in any lead, okay? Sgarbossa A, any lead. Sgarbossa B, only in these mid-precordial leads. Sgarbossa B only works in those. I will add in lead V1, okay? Dr. Sgarbossa does not add that in, but I will add in lead V1. And lead V1, I think, is important. You could definitely see it. And lead V1, you could. So we're going to stick with that, all right? But V2, V3, V4, that's where Dr. Sgarbossa noted those. If you have this right here, or you have this right here, then there is a 94% chance your patient is, in fact, having an MI. And that patient needs to go to a cath lab. They need to go to a cath lab. You got to take them, okay? So, it's a left bundle branch block. I can't tell if it's actually an MI or not. Yes, you can. With 94% accuracy, and you know what? That's good enough for me. 94% accuracy, I'm taking that patient to the cath lab. All right, so let me erase this stuff and go over Sgarbossa C, okay? Now, Sgarbossa C only has about a 60%, it's only about 60% accurate, so I'm careful with Sgarbossa C. Sgarbossa C says that there is something called abnormal discordance, okay? Abnormal discordance. And that means that if the J point up here, and let's say this is probably the J point right there, if the J point is greater than 20% higher, right, or 20% the size of the QRS itself. So let's say the QRS, here is, I don't know, let's say the QRS is 5 millimeters, right? Okay? Well, 1% of 5 millimeters is half a millimeter. So that means 20% of 5 millimeters would be how much? 20% of 5 millimeters would be a full millimeter. So in that case, if I'm talking about a 5 millimeter QRS, then I would be looking at a J point that's elevated, 2 millimeters above the baseline. That would be considered abnormal discordance. Well, that's a problem because remember, when I have that odd depolarization, I have odd repolarization. So that's why Sgarbossa criteria C is only about 60% accurate. This is one of those, I'm going to be careful. I'm probably going to call the doc or call the hospital ahead, let them know what I've got, and then patient history is going to mean so much. If this guy, in fact, is having chest pain and all of that, and there's no knowledge that he's had a left bundle branch block in the past or anything, you know what? With this patient, I might just say, I'm probably going to go ahead and take this guy to an ER with a cath lab, especially if he's complaining of chest pain, shortness of breath, cool, pale diaphragm. You are going to the cath lab, or you're going to a place with a cath lab. They'll draw troponins on this patient. They'll see if he needs to actually go into the cath lab. He may. But it's only 60% accurate, okay? So Sgarbossa C, I tell you about it, but I would not be putting that on a test. I'm not going to require you to make a decision on whether or not your patient is having a STEMI based on Sgarbossa C. I will be focusing only on, whoops, I went back too far, I think. Oh, no, I didn't. Oh, that's right, I erased it. I would be focusing only on Sgarbossa A and Sgarbossa B. And Sgarbossa A is concordant ST elevation in any lead. Sgarbossa B is concordant ST depression in V1, V2, V3, or V4. Any one of those. Okay? Any one of those. All right, I hope that clears it up. All my best.